So, welcome to today's session of anatomy, part of the recorded lectures. I'm Dr. Vinay Sundar. So, anatomy plays a very vital role with respect to the Royal College of Surgeons examinations, especially with respect to Dpcd and MFD. So, in almost every exam, we're going to have at least one question from anatomy with respect to MFD2 out of the 15 stations. And with respect to MFD1 and Dpcd, there hasn't been questions which do not relate to anatomy. So make sure head and neck anatomy with more focus on oral anatomy plays a vital role in your reading and revisions. So we start with the skull when seen from the superior point of the view. I would refer or request you to go through the Netter's book of anatomy where they have the same color coding for the bone. For example, if frontal bone is blue in color, it's going to look blue in either of the sagittal view or coronal view or lateral view, and that way you're able to correlate as to whichever angle it is. So in this particular angle, what we see here is the frontal bone. Then you have the parietal bone, which is a paired bone. Paired bone means one on either side, and then you have the occipital bone. The other important thing here with respect to this view is this is the coronal suture. Now coronal means crown, so imagine like somebody is going to put a crown on top of your head, right? So in that angulation or in that position, that is why this is known as the coronal suture. And this is going to known as a sagittal suture, similar to the sagittal sections of a CT scan. So where you're going from the lateral of one side to the lateral of the other side. So in what way the suture divides the skull or is running across the skull, that's the way they have given the name, or that rather derive its name. And then you have your occipital suture here, the lambdoid suture here. Why is it called as a lambdoid suture? Is because of the lambda shape here, the inverse Y Greek shaped here. So the sutures with respect to the superior view of the skull is the coronal suture, the sagittal suture, and the lambdoid suture. Now, the meeting points are the sagittal and the coronal suture here, which is known as the brecma, and the sagittal suture and the lambdoid suture, which is known as the lambda. So that's it with respect to the superior view of the skull. You need to remember that the posterior fontanelle closes at the 6 months of stage first, that is about half a year, and the anterior fontanelle, which is present in much more in the anterior region, that closes approximately in 1.5 years to 2 years, which is about 18 to 24 months. So you have parietal emissary veins which connect with the superior sagittal sinus along with the occipital veins. The point to notice, these are valveless veins. Now we're seeing the same structure from the posterior point of view. So we saw this, the same sagittal suture, which is running across the center of the skull, dividing into two parietal bones here. And what you see here is the parietal foramen, and this is your lambdoid suture. Here you can appreciate the lambda symbol in a much more easier way, the upside down Y. And this is the occipital bone, or is the posterior most bone here. Now, when you're able to, palpate at the behind your head, you can see a very thick protuberance. What is known as external occipital protuberance. And the other important structures are your styloid process, then you have your mastoid process, then you have your stylomastoid foramen, then you have your temporal bone. This is the foramen magnum through which your skull passes. Now the frontal skull here. Now we say the skull from the frontal view. So here we have your frontal bone here, then you have your paired maxilla bone here, then you have the orbit here, then you have your mandible here. And this is the zygoma, also a very popular bone amongst the maxillofacial surgeons because it frequently gets fractured. And then you have, this is the orbit here. You need to remember the orbit is made up of 7 bones, and you need to know all these 7 bones. Apart from this is the nasal bone, which is also the pair of bone. Then you have the perpendicular plate of ethmoid here, and the other parts of the mandible, which include the ramus, body, mental foramen, mental tubercle, and mental protuberance. Then you see in the maxilla here, you have your zygomatic process, the orbital surface, infraorbital foramen. This is the infraorbital foramen, and the infraorbital nerve exits through the infraorbital foramen. Can get damaged during facial trauma or other paresthesia. That's what we're discussing about during maxillofacial fractures here. And So, like I said, the 7 bones which form the armit, you need to know them are the sphenoid bone. Can you see the sphenoid bone here? So this is the sphenoid bone. Then you have your frontal bone. Then you have your zygomatic bone, ethmoid, lacrimal, maxilla, and the palatine bone. So a very popular question, and they've asked questions about the fracture of the floor of the orbit. So all these need to be recognized, but make sure, I repeat, the 7 bones of the orbit are the sphenoid, frontal, zygomatic, ethmoid, lacrimal, maxilla, and the palatine. Now we come to the lateral view of the skull. So we're going to see the same set of bone, but the only difference is from the lateral view. So here, the coronal suture remains the same here, frontal bone. Try to orient yourself in whichever position you see the skull, whether it's the top or from the behind or from the side or from the front, you should be able to identify all the bones. If you do that, this particular osteology becomes pretty much easy. Then you have your frontal bone here. Then I said the parietal bone here. Here we are able to see only one side. The other side is on the obviously on the left side, which you're not able to see here. Then you have your occipital bone here. Then you have your temporal bone here. Then you have your sphenoid bone, which also forms one of the orbit. And then you have your maxilla bone, and this is the zygoma. And this part of the zygomatic bone is the what is known as a zygomatic arch. So if someone asks you what forms a zygomatic arch, it is formed by the zygomatic process of the temporal bone and the temporal process of the zygomatic bone. So this is how it works. And you have your frontonasal suture, supraorbital foramen, and the mental foramen. The mental nerve exits through the mental foramen. Then you have your mental protuberance, and this is the mandible. Now again, you can see a styloid process and your mastoid process. Okay, so zygomatic process of the temporal bone and temporal process of zygomatic bone forms the zygomatic arch. Zygomatic arch is fractured during an assault. So when someone tries to hit you, right, obviously in order to defend or, protect yourself, you move your face, and that time, whatever, whether it's a rod or a slap, it lands here. So that's why the zygomatic arch is more commonly fractured during an assault. And when you ride on a bike or something, you fall again on the sides, the zygomatic arch is fractured here. Now, some of the things which you need to remember is the masseter muscle arises from the lower border of the zygomatic arch, and the arch that is crossed by the facial nerve, and its root is by the auriculotemporal nerve. Now, the superficial temporal artery is going to be another structure which is closer to the zygomatic arch, and it is one of the branches of the external carotid artery, which we'll be seeing in detail here. Now, this is another sagittal section of the skull here. This is the section you get to see during a lateral cephalogram or a cephalogram, depending upon pronunciations of various people. Now we'll again briefly go through the same set of structures here. So this is the parietal bone here. Then you have your temporal bone here. Then you have your styloid process here. This is a styloid process. This is your sphenoid sinus. And this is your hypophyseal fossa, also known as sella turcica. It houses the pituitary gland here. A very, very important and a popular question. Now, what you see this side is your inner side of the mandible, right? So usually we see the outer side of the mandible. This is the inner side of the mandible here, though. So this is the mylohyoid line, which serves as the attachment for the mylohyoid muscle, which is the floor of the mouth. Then this is the mandible. Then this is the hyoid bone, and this is your mandibular foramen. All of us know the inferior alveolar nerve enters, or rather, let's say, enters to the mandibular foramen. Then you have your lingula. This is the landmark for your inferior alveolar nerve. So this is the cribriform plate and the perpendicular plate of ethmoid. This is your nasal bone. The cribriform plate is usually fractured during your leaf-foot fractures, and that is the reason it leads to CSF leak. And you have your medial and lateral pterygoid plates. You can see this, follow this here. Medial and lateral pterygoid plates, they serve as attachments for the medial and lateral pterygoid muscle. This is pretty much simple. The sinuses are air sockets and paired. So frontal sinuses, then you have your ethmoidal air cells, then you have your eye sockets, then your sphenoid sinuses, and your maxillary sinuses. Ideally speaking, the sinuses are nothing but filled with air to reduce the weight of the skull. So that's why when you have a cold, or sometimes when you have some fluids in one of the sinuses, your head feels heavy. That's why it's difficult for you to have a tough time. So unless the fluid is completely gone out or other exits, it's difficult for us to function properly. So these are the functions of the sinuses that are usually paired. Now, this is rather I would say the inferior view of the skull here. So selected foramens need to be identified. You should be able to identify the foramen, and you should also be able to identify the structures passing through the foramen. So here and there, I'll be able to give you some mnemonics. So try to remember the mnemonics so that you don't forget it. Now, what you see here, this is the zygomatic arch, right? So this you see the zygomatic arch. We described the zygomatic arch is formed by the zygomatic process of the temporal bone and the temporal process of the zygomatic bone. This is your incisive foramen, a landmark for your nasopalatine nerve block. Now, let's go to the foramen alone in this slide. So this is your foramen ovale. You can see here it's oval in shape, and that's why it's known as foramen ovale. Then you have your foramen lacerum, slightly bigger than the foramen ovale, but much more medial. Medial means towards the midline. Then you have your foramen spinosum, which is slightly small, and immediately next to your foramen ovale. Then you have your foramen lacerum and stylomastoid foramen, and this is the biggest foramen, which is known as the foramen magnum. The foramen rotundum is also not, it's supposed to be round in shape, not much appreciated in this slide, but I'll show you in the next slide along with the structures passing through it. Now, yes. So in your exam, you're going to be asked to identify this foramen and structures passing through it. Okay. So this is the foramen ovale. Okay. Something which is superior to it or on top of it is the foramen rotundum. Now let's see if you're able to identify this. So this is the foramen ovale. So your foramen rotundum is somewhere here. It's not able to see in this particular slide. So we're going to use this for reference. This is the foramen rotundum, round in shape, and this is the foramen ovale. This is the foramen lacerum, like I said, is going to be towards the midline. And this is the foramen spinosum, which is present immediately behind your foramen ovale here. And then you have the biggest foramen, which is the foramen magnum. And you have your other foramens. There are loads of other foramens. But from an MFD point of view, for a dental exams point of view, you don't need to learn them all. But if you feel you can learn, well and good, nobody's stopping you. So this is the superior orbital fissure here. So superior orbital fissure here, the structures passing through are the cranial nerves with respect to the extraocular movements, and along with it, you have your that is the oculomotor, trochlear, and ophthalmic, and you have your abducens nerve, then your superior ophthalmic vein and ophthalmic nerve here. Now, optic canal, the optic nerve and ophthalmic artery passes through. The optic nerve is another cranial nerve which is necessary for vision. Now, foramen rotundum, the mnemonic is, what do I say? The maxillary nerve passes to the foramen rotundum, and the mandibular nerve passes to the foramen ovale. Now, this is the way I used to remember this and see if it works out for you. So imagine, so this is a round, okay, and this is the oval, right? So this, what, if you see this without any, generally, suppose you see the sign on a board or something, this looks like the stick figure of a person, right? Which means this is the head, and you can see this is the trunk region. So the one which is on top is for the maxilla, and the one which is bottom is for the mandibular. So the foramen rotundum passes through the maxillary nerve, and the foramen ovale, I'm sorry, the maxillary nerve passes through the foramen rotundum, and the mandibular nerve passes through the foramen ovale here. Got it? Now, other structures passing through the foramen ovale, the mnemonic is MALE, male, where M stands for mandibular nerve, A stands for accessory meningeal artery, L stands for lesser petrosal nerve, and E stands for emissary veins. So we finished foramen rotundum and foramen ovale. With respect to foramen magnum, if you know that the medulla oblongata or the spinal cord passes through the foramen magnum, that is more than enough. Coming to the foramen spinosum, a very interesting thing is that there is an artery, there is a vein, and a nerve. So usually anatomy, we read about arteries, nerves, and veins, right? So there is one artery, one vein, and one nerve passing through the foramen spinosum. But everything is related to the meningeal or the branch which goes to the brain. So you have middle meningeal artery and vein, and the meningeal branch of the mandibular nerve with respect to foramen spinosum. So foramen rotundum, see this maxillary nerve, foramen ovale, MALE, mandibular nerve, accessory meningeal artery, lesser petrosal and emissary veins, and foramen spinosum, one artery, one vein, and one nerve related to the meningeal regions. And you have your foramen lacerum, which talks about the meningeal branch of the ascending pharyngeal artery, some more emissary veins, and internal carotid artery and greater petrosal. Okay, so this is about the foramen or base of the skull and its contents. Now, this is the skull base, and it can be divided into three. The one which is in black dots, that is known as the anterior cranial fossa. The one which is present here above the foramen magnum, maybe with the brown color, that is known as the middle cranial fossa, and this is the posterior cranial fossa. What you need to know is the structures which are present there. So anterior cranial fossa, it has the frontal lobe of the brain, the floor, and the roof of the orbit. With respect to the middle, you have your midbrain and the floor at the zygomatic arch. And the posterior is brainstem and cerebellum. floor tentorium cerebelli, and zygomatic arch. If you are someone who's reading anatomy after a very long time, don't worry. Just keep reading this on a daily basis and understand and orient yourself. If you try to mug up anatomy, it's not going to help you. You need pictures and you need to know why is it. Okay, this is the cranial fossa. Cranial fossa means cranial head fossa. It's a cavity. It's divided into three. The one in the front is going to be anterior. The one in the center is going to be middle. The one in the behind, which is most posterior, is known as the posterior. Then see how where the structures are: the roof of the orbit, then zygomatic arch, then floor of the tentorium cerebelli. The more you orient yourself, you will feel better and you won't forget easily. TMJ, very popular and very interesting. Like any day, a dentist is going to know better about the anatomy of TMJ than any other any other specialist. So the components are the head of the mandible and the glenoid fossa. So this is the head of the mandible. This is the glenoid fossa. It's also known as an atypical joint because it is the only paired joint of the body and is separated into upper and lower cavity by the disc. And I say only paired in the joint, you might ask me, like, even the knee is paired, your elbow joint is also paired. But suppose your right side joint is injured or damaged, still your left can function, right? But in case of TMJ, both of them have to work synchronously or simultaneously. So there's one other region, it's known as atypical, and the other is obviously because it is separated to the upper and lower by the disc. So the disc is attached to the inside of the capsule, and the posterior lamina has a lot of elastic tissue allowing it to recoil. So you need the disc to recoil, okay? You need to stretch something like a rubber band, then it has to recoil, come back to its original state. So if it's going to be only not allowing it to recoil, then there's going to be very difficult movements with respect to temporomandibular joint. One another clue is any muscle related to the temporomandibular joint, always remember it's only the lateral pterygoid. The medial pterygoid is nowhere near the temporomandibular joint, and the masseter and the temporalis are also nowhere near the temporomandibular joint. So any muscle related to a TMJ, kindly remember it's the lateral pterygoid. So you have your superior head of the lateral pterygoid and you have the inferior head of the lateral pterygoid. So this is the mandibular fossa or the glenoid fossa. And obviously this is the disc, which is going to divide it into two cavities, the superior synovial cavity and the inferior synovial cavity. Retrodiscal. Retro means going behind. So one which is present behind the disc is retrodiscal tissue, and this is our favorite condyle. So can someone identify this? It's a styloid process. Yeah. Now, characteristics of a synovial joint is it's going to be a congruity, ball and socket. You have a synovial membrane, and the synovial fluid is viscous. Now, what is viscous? Viscous is a physical property of a fluid. For example, you have some water in a glass. In the other glass, you're going to have some oil. You're going to pour, the water is going to flow very freely, but oil will also flow, but it's not going to flow as freely as the water, right? So what makes the water flow less easily? Because the oil is more viscous than water. So similarly, your synovial fluid is more viscous. Why is it viscous? Because of the presence of polysaccharides like hyaluronic acid. Now, what is the job of this synovial fluid? Is going to lubricate the joint. Lubrication is, you've seen your door hinges or your cars and all that constantly needs to be lubricated. Only it function easily, because if it dries up, then it's going to be difficult for the joint to function, right? The other action is scavenger, or going to remove the debris. Any waste material is present, is going to help them remove. So this is the function of synovial fluid. And one other thing which I wanted to ask you, yes. So obviously when you are doing this arthrocentesis, right, process, the function of arthrocentesis is to remove the debris, right? So job which is not done by the synovial fluid, the lubrication is done by the arthrocentesis process, so that the joint is able to move freely. So auricular temporal nerve and the deep masseteric nerve are the ones who's related to temporomandibular joint, where the blood supply is in the superficial temporal artery. So these are some of the ligaments which have a check on the movements of the temporomandibular joint. This is the spinomandibular ligament, stylomandibular ligament. So there is mandibular, spino from the sphenoid process, and stylomandibular attached from the styloid process. Okay, and this is the capsular ligament. TMJ muscles. So you have the four muscles. Actually, this is not the TMJ muscles, the muscles of mastication. Sorry, ignore the slide on the top. These are the muscles of mastication. So you have four muscles of mastication, which is your masseter, temporalis, medial pterygoid, lateral pterygoid. Now, for your exam, you need to know your origin, insertion, innervation, function. Origin is from where the muscle starts. Innervation is from where the muscle ends. Insertion is where the muscle ends. Innervation is the nerve supply, and the function is what is its role. Okay, so first, this is the masseter muscle. So where does this originate from? This is the zygomatic arch. So you can simply write zygomatic arch or the maxillary process of the zygomatic bone here. And where does it insert? Onto the lateral surface of the ramus of the mandible. Very simple. So it starts from the zygomatic arch and maxillary process of zygomatic bone, goes down and ends up in the lateral surface of the ramus of the mandible. Okay, very simple. Now the temporalis, this is the biggest muscle of mastication amongst the four muscles. So you have the bone of temporal fossa and temporalis fascia. So you know this is the temporal fossa and temporalis fascia, and it goes down and attaches near your coronoid process and anterior margin ramus of the mandible, almost to the last molar of the tooth. People familiar with oral surgery know that when you're giving an incision for your warts, you're not supposed to go too superiorly because it's going to damage your temporalis. So that is where your insertion of your temporalis is. It's a fan-shaped muscle. So origin, this is your bone of the temporalis fossa and goes down coronoid process of mandible and anterior margin of mandible almost to the last molar tooth. Now, medial pterygoid and lateral pterygoid. Okay, there are two muscles. The only thing you need to remember here is, see the origin of medial pterygoid. Medial pterygoid has two heads. It has a deep head and a superficial head. And the lateral pterygoid has an upper head and a lower head. Now, with respect to medial pterygoid, the deep head originates from the medial surface of lateral plate of pterygoid process and the perimeral process of palatine bone, while the superficial head originates in the tuberosity of the maxilla and the pyramidal process of palatine bone. Where is the tuberosity of the maxilla? Posterior to your third molar, right? That is the tuberosity region. So medial pterygoid originates in the lateral plate, medial surface of the lateral plate of pterygoid process. Now coming to lateral pterygoid, the upper head originates from the roof of ITF or the infratemporal fossa, while the lower head originates from lateral surface of lateral plate of the pterygoid process. The point to note here is, both your medial pterygoid and the lateral pterygoid originate from only the lateral plate of the pterygoid process. If it is from the lateral surface of the lateral pterygoid process, that's why it's given its name as lateral pterygoid. If it's going to give its process from the medial pterygoid, that is known as your medial process of the lateral pterygoid plate, and is known as your medial pterygoid. Obviously, it has two heads, deep head and superficial head for medial pterygoid, but for lateral pterygoid, it's upper and lower. Now, insertion, medial surface of the angle near the mandible. That's why you generally see the, this is your, what do I say, the deep head and superficial head of the medial pterygoid, the inner surface. Can you see the one in red and orange in color? With respect to the lateral pterygoid, it's very close here. That's why it's any question related to the muscle and temporomandibular joint, the answer is lateral pterygoid. So you have a superficial head and deep head. Now, if you see the upper head, roof of ITF, infratemporal fossa, while the lower head originates from the lateral surface of the pterygoid process. Capsule to TMJ, attaching here the capsule of temporomandibular joint. So these are the muscles of mastication here. Now we have a digastric muscle here. Sorry, I forgot to mention about the functions. So the masseter, powerful elevator. Elevator, see, my jaw is open now. It has to elevate, only the jaw will close. This is known as the elevation of the mandible. Temporalis, elevation as well as retraction. Protraction is bringing the mandible forward and retraction is bringing the mandible backward. Medial pterygoid, elevation as well as side-to-side movements of the mandible, while lateral pterygoid, protrusion and side-to-side movements of the mandible. Okay. So medial pterygoid, elevation and side-to-side movements, while lateral pterygoid, protrusion and side-to-side movements. So these are your rows of muscles of mastication. Digastric muscle. So digastric, this is the muscle which is shown in green in color. So it has two bellies united by an intermediate tendon. This is the intermediate tendon here. So origin for the anterior belly, the one which is present in front, is the digastric fossa. And the posterior belly originates from the mastoid notch of the temporal bone here. This is the posterior belly origin. This is the anterior belly. Insertion, both these bellies meet at the common or the intermediate tendon and is held by a fibrous pulley to the hyoid bone here. A very important point to note is the anterior belly of the digastric is supplied by the fifth cranial nerve, which is your trigeminal nerve, and the seventh cranial nerve, which is the facial nerve, supplies your posterior belly of digastric. Okay, so you need to know what are the cranial nerves from 1 to 12, and you need to know what, with, like, for example, if 5 is trigeminal, 7th is facial, and all that. So this is a mnemonic which I found online. Personally, I couldn't, relate to this mnemonic. But if you feel, I thought like maybe some of you might find this easier. So you can use this mnemonic or you correlate. So I'll just read out one. So one is for your smell or rather, you're able to smell, it's olfactory. That's why it's known as special sensory, because it can only that nerve can help with respect to your smell. The second is your optic nerve with respect to vision. That's why it's known as special sensory. Now, oculomotor, trochlear, as well as your abducens are all going to come under motor. Motor is when you want to do something. You're going to move your eyeballs. That's why it's going to help in extraocular movements. So 3, 4, and 6. Third is oculomotor, 4 is trochlear, and 6th is abducens. Now, in between trigeminal nerve, all of us have heard of a trigeminal nerve. It's a mixed nerve, meaning it can be sensory as well as motor. Now, the 8th is the vestibulocochlear nerve. It's a special sensory. It usually helps in maintaining balance. Then you have your glossopharyngeal nerve. It's special sensory, autonomic, as well as motor. So general sensation as well as taste. Then you have your vagus nerve, sensory, motor, and autonomic, which is the 10th cranial nerve. 11th is accessory nerve, your spinal accessory nerve. When damaged during neck dissections or cancer surgeries, you can result in patient drooping of shoulders. Then you have your hypoglossal nerve, which is responsible for your protrusion or the extra tongue movements rather. So I'll quickly read through again. 1 olfactory, 2 optic, 3 oculomotor, 4 trochlear, 5 trigeminal, 6th is abducens, 7th is facial, 8th is vestibulocochlear, 9th is glossopharyngeal, 10th is vagus, 11th is accessory, and 12th is hypoglossal. This is a mnemonic or rather a way to understand the extrinsic eye muscles, like how your eyeballs move here. Okay. Now there are 2 groups of muscles here. One is recti group of muscles, the other is the oblique muscles. Okay. So recti means 4 groups of muscles: medial, lateral, inferior, superior. 4 directions: medial, lateral, inferior, superior. Oblique, superior, and inferior. Okay. So first, get that straight. Recti muscles, you have medial, lateral, superior, and inferior. And oblique, it's only superior and inferior. Now, you need not know the origin and insertion with respect to extraocular muscles, but action and innervation you need to know. So with respect to recti muscles, it's going to do what the name says. Medial recti moves the eye medially. Lateral recti moves the eye laterally. Now, they would have used the term here adduct and abduct. So abduct is like, abduct is usually use the term abduct for kidnapping someone, right? So you're going to take somebody and then move or run away, right? So moving laterally is known as abduction, and moving medially is known as adduction. If you can remember this way, remember, but this is how I remember. So medial rectus, the recti group of muscles, is going to do this name which the direction says. For example, medial is medial movement, lateral is lateral movement. Inferior recti is going to move inferiorly as well as medially. Inferiorly as well as medially. Superior recti is going to do superiorly and medially. Okay, superiorly and medially. Now, what are we left with? See, we have found the muscle which helps it move medially. The one moves it laterally. Now, what about superior and superior lateral movement and inferior lateral movement? And that's how your oblique muscles are. The oblique muscles will do the opposite. The inferior oblique will move the eye superiorly. Inferior is going to move superiorly and laterally, while superior oblique is moved to move inferiorly and laterally. The superior medial is already done by your superior rectus, and the inferior medial is moved on to your inferior rectus. So whatever movements is rest is nothing but your inferior oblique and superior oblique, right? So I'll quickly move through 2 groups of muscles, recti and oblique. 4 groups of muscles for recti in 4 directions: superior, inferior, medial, and lateral. With respect to oblique, it is just 2, superior and inferior. Recti group of muscles will do the same set of direction as the name suggests. Medial recti means medial movement. Lateral recti means lateral movement. Inferior recti is going to do inferomedially, while superior rectus is going to superioromedially. Now we're coming to the second group of muscles, which is the oblique. The inferior oblique is going to do superior laterally, opposite of inferior of inferior. And superior oblique, what is the opposite of superior? Inferior. So inferior laterally. Now, with respect to innervation, you just need to remember this. All the groups of muscles are innervated by the 3rd cranial nerve, which is the oculomotor nerve, except for LR6SO4. This is how what is the mnemonic to remember is LR6SO4. LR6SO4. What does LR6SO stand for? The lateral recti, LR, is innervated by the 6th abducens nerve, and the SO4, superior oblique, is innervated by the trochlear nerve, 4th nerve. Rest, all the extraocular muscles are supplied by only the oculomotor nerve. So the mnemonic to remember is LR6SO4. So the damage to the sympathetic plexus results in Horner syndromes, And sometimes you can have drooping of eyelids or ptosis or some of the damages to the extraocular muscles. Very easy this. Just try to listen to this again, orient yourself. See, anatomy or with respect to any subject, it's not like you listen to the lecture and you're going to understand. You're going to retain it for a longer time. Repeated readings, repeated revisions is what going to help you out. Branches of the maxillary artery, it was asked quite some time. So this part, the diagram is very, very complicated here. So I just put up, what do I say, kind of mnemonics. So try to orient. The first part is MAD AI. So artificial intelligence is MAD. So what does the MAD AI stands for? Middle meningeal, accessory meningeal, deep auricular, anterior tympanic, inferior alveolar. All of them are arteries. Okay, these are only everything 11 artery. You can't confuse saying nerve and all that. Second part, buccal. The simple way to remember is is somewhere close to the related the muscles of mastication. So what are your muscles of mastication? Masseter, temporalis, pterygoid, and So masseter, temporalis, medial pterygoid, lateral. So masseteric artery, deep temporal artery, and pterygoid artery. The only additional is your buccal artery. Okay, so second part is somewhere closest to your muscles of mastication. Only the names. The third part is either connected as PIC pass or PIC sap. So posterosuperior, infraorbital, greater palatine, sphenopalatine, artery of the pterygoid canal, and pharyngeal artery. So these are all arteries usually arising from the maxilla part, closer to your palate. So posterosuperior, infraorbital, greater palatine, sphenopalatine, artery of pterygoid, and pharyngeal artery. You need to mug up. There is no other. With respect to the branch of the external carotid artery, remember I told we'll be revisiting this. So this is a very popular mnemonic. Sister Lucy's powdered face often attracts medical students. So Sister S stands for superior thyroid, L stands for lingual, P stands for posterior auricular, F stands for facial, O stands for occipital, A stands for ascending pharyngeal, M stands for maxillary, S stands for superficial temporal. You need to remember the mnemonic. This mnemonic is for the branches of the external carotid artery. Okay, so there is something called as a common carotid. The common carotid bifurcates into the external carotid and the internal carotid. The internal carotid supplies the eye and the brain, while the external carotid usually supports the head and neck region, including the face. These are the branches of the external carotid artery. Triangles of the neck, very, very popular, very famous questions. A lot of times it has been asked. So very simple. I'm going to explain this to you. So imagine the neck to be a quadrilateral. Okay, so quadrilateral is a four-sided figure. Now you draw a diagonal. The diagonal is nothing but your sternocleidomastoid. So once you draw the sternocleidomastoid, you will have two triangles. I'm talking the big triangles. So one in front of the sternocleidomastoid is anterior triangle. The one which is behind the sternocleidomastoid is the posterior triangle. Now, posterior triangle is very simple. What are the boundaries? Triangle has three sides. The posterior, the sternocleidomastoid, you have your clavicle here, and this is your trapezius muscle. So these three muscles form together what is known as a posterior triangle. End of story. Now come to the anterior triangle. Now, first is the submental triangle. Now, remember we studied the digastric belly, two bellies of anterior belly of digastric, right? So these two bellies form two sides of the triangle and the base of the mandible. That submental, that is below your submental region, is known as a submental triangle. Now, the next is your submandibular triangle because it houses the submandibular gland. So you have your anterior belly of digastric on one side, your posterior belly of digastric on the other side, and your mandible here. This is your submandibular triangle. Now, okay, so this is the submental, below the submental region, submandibular. Now you have your carotid triangle. Now, carotid triangle is formed by your posterior belly of digastric, part of your sternocleidomastoid, and your superior belly of omohyoid. Now, this is the omohyoid muscle. So the sternocleidomastoid divides it into superior belly and inferior belly. And this is the carotid triangle here. Very important. Remember, the superior belly of omohyoid, sternocleidomastoid, and the posterior belly of digastric. Now, what are you left with? You're left with only the muscular triangle, which is formed by superior belly of omohyoid, the lower part of the sternocleidomastoid, and the midline. So please orient yourself. So neck is a quadrilateral divided by the sternocleidomastoid into anterior and posterior triangles. And posterior triangle, very simple, sternocleidomastoid, the trapezius muscle, and the clavicle. For the anterior triangle, the subdivisions are two anterior bellies of digastric muscle along with the chin is going to form the submental, is called the submental triangle. Then you have an anterior belly and posterior belly and the mandible in the submandibular triangle. Then with respect to superior belly of omohyoid, then this posterior belly of digastric and the sternocleidomastoid, this is the carotid. And the one which is present below that is the muscular triangle, which is the superior belly of omohyoid, your sternocleidomastoid, and the midline. So branches of the facial nerve. So usually you remember see the very popular diagram where you keep your face, the 5 fingers across the face and divide it into 5 branches. So temporal branches, zygomatic branches, buccal, marginal mandible branches, and cervical branches. Some of the muscles which are supplied by these respective branches are platysma, mentalis, depressor labial inferioris, depressor anguli ori, orbicularis ori, buccinator, zygomaticus, and for zygomaticus, orbicularis oculi. So oculi is eye and ori is lips. Note the differences. And temporal branches, frontalis, orbicularis oculi, corrugator, suprasupine. So these are some of the muscle facial expression you ask the patient to do to test the respective branch of the facial nerve. You can ask the patient to forcefully depress and draw the lower lip laterally while maintaining the mandible in a position of slight depression. So this is what you're talking about. You don't need to know about isometric platysma strengthening here. Now the branches of trigeminal nerve. Trigeminal nerve is the 5th cranial nerve. It's a mixed nerve. It has ophthalmic, maxillary, and mandible. So ophthalmic, remember the mnemonic is funnel, FNL. Need to know frontal, lacrimal, nasociliary. With respect to maxilla, it's the meningeal branches, the one which goes to the brain. Then the ganglionic branches, the one which supply the palatal region, greater palatine, lesser palatine, nasopalatine. Then you have your posterior supraalveolar nerve where you give your block, PSA block. And 4th is your infraorbital nerve here, which is again divided into anterosupraalveolar and middle supraalveolar. And your 5th is your zygomatic nerve, which is again divided into zygomaticofacial and zygomaticotemporal. So remember, ophthalmic, it's funnel, FNL. For maxillary, meningeal, they're going to the brain. Ganglionic, posterosupraalveolar, infraorbital, zygomatic nerve. So you need to know about maxillary, but more questions are asked towards mandibular nerve. So you have your nervus spinosus, which is one of the branches of the mandibular nerve. It has its meningeal branch. Remember, meningeal branch of the mandibular nerve, which goes to the nervus spinosus, one branch, one nerve, one artery, and one vein. That is what this nervus spinosus is about. Then you have your motor branches, anterior divisions and posterior divisions. Now, anterior divisions, this is very similar to the second part of the maxillary artery. That is an artery and this is a nerve. Don't get confused. But I'm saying just for the sake of remembering. Nerve to lateral pterygoid, we had a pterygoid artery there, then masseter, deep temporal, and buccal nerve. A very, very popular mistake made is someone asks which nerve supplies the buccinator. People tend to say it's as the buccal nerve. No, it's the facial nerve. Buccinator is the muscles of facial expression, so it will be supplied only by the facial nerve. Buccal nerve and long buccal nerve are the same. So the anterior division are nerve to lateral pterygoid, which is similar to muscles of mastication. The pterygoid, masseter, deep temporal, and buccal nerve. The posterior division, the mnemonic is ALI, A-L-I. So auriculotemporal nerve, lingual nerve, and inferior nerve. Inferior nerve, we always anesthetize during our mandibular procedures, nerve blocks. So nerve to mylohyoid and mental nerve are the other branches of inferior alveolar nerve. Tongue. So we saw the extrinsic muscles of the tongue. So genioglossus, hyoglossus, styloglossus, and the palatoglossus. So we know all the muscles of the tongue are supplied by the hypoglossus nerve, except for the palatoglossus, which is supplied by the vagus nerve. With respect to the innervations of the tongue, so you have your anterior 2/3 and posterior 1/3. So in respect to anterior 2/3, the lingual nerve is going to provide your general sensory sensation. The chorda tympani is going to provide your special, your taste sensation. With respect to posterior 1/3, both the general as well as the special taste is going to be provided by your cranial nerve 9, which is your glossopharyngeal nerve. So I repeat, for anterior 2/3, lingual nerve is going to provide your general sensation, which is why when someone gives an inferior nerve block, the tongue becomes numb because your lingual nerve is anesthetized. Your chorda tympani nerve gives a special sensory nerve, a branch of the facial nerve, 5 and 7. But with respect to the posterior 1/3, it's the glossopharyngeal nerve, which is very, very common for the both general as well as space the taste sensation. So that's it for anatomy. These are one of the most popular questions asked in anatomy. Anatomy, you guys need to have it at your fingertips. In case of any doubts, refer textbooks. Frame your own mnemonics. So it can be in your regional language, or it can be in English or anything. If you feel you have a good mnemonic, do share it with us. You can share it with it. It will be always useful. So when you help people, help comes back to you. It's a very simple circle. So I don't think I've missed anything here. So in case I have missed something, you can always mail me at dentalclinicavs@gmail.com, and you have my number 918056205321. That should pretty much tell me like if I missed some question. These are the most popular stations of anatomy. If is there anything, something which I missed out, I will add a subsequent small, lecture combining with some other subjects to combine anatomy. Thank you. Thank you so much. Please do share your feedback for the recorded lecture.